Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got a 100% on my NPTE, and this led me to co-found SPT with me, which is an NPTE prep platform. If you enjoy what you see and you're studying for the NPTE, check out our courses at sptwithme.com. Now, for what you're actually here for, let's talk about Cranial Nerve 12, the hypoglossal nerve. This image shows an anterior to posterior view of the thalamus and brainstem. As you can see, there are multiple rootlets that exit the medulla ventrally. Here's an image that takes out the rest of the clutter of information and hopefully makes seeing where the nerve exits a little bit easier. This is a posterior to anterior view, same structure, thalamus and brainstem. So we're looking at the back side. In this view, you cannot see where the rootlets exit since they are exiting the front side of the brainstem. But here you can see the hypoglossal trigone, and this is a part of the brainstem that physically protrudes. This is the site of the hypoglossal nuclei. This is the same structure and it's the same view, but in this image you can see the nucleus and really how long it spans up and down the brainstem. This is now a lateral view, same structure, thalamus, brainstem, but here you can see how the nerve exits the brainstem ventrally. So what does this nerve actually do? It is a purely motor nerve, and it innervates all the intrinsic and almost all of the extrinsic muscles of the tongue. On the slide, you see a very long list of all the muscles of the tongue that it does innervate. Realistically, you don't need to memorize these, but I would say a good one to note is the genioglossus muscle. And you want to note this because this is the one that we actually test and look at when we address the function of the tongue. So think about cranial nerve testing. However, just understand that all the movements of the tongue are due to the innervation of this nerve, cranial nerve 12. Let's talk about the pathways. Because there is some crossing over that happens in this pathway, it might seem a little bit confusing, but let's break it down and try to make it easy. So we start at the primary motor cortex of the brain, and that's because this is a motor nerve. The brain is what tells our nerves what to do. So we're going to start at the brain. So we're going to start at one side of the brain, and I want you to look at the right side of the brain. So in our point of view, it's the left side of this picture. Here you can see that the nerve starts in the brain and then it loops its way down toward the brainstem. As it reaches the brainstem, you can see that it actually crosses over to the contralateral side. So in this case, the nerve starts in the right side of the brain, but then when it reaches the brainstem, it ends up being on the left side of the brainstem. This crossing over happens prior to reaching the hypoglossal nucleus that we already mentioned. This piece of information is very important because the presentation of an impairment with an upper motor neuron lesion is going to be different than that of a lower motor neuron lesion. This picture in particular is not the best image to explain it. You know, the skull is not in an anterior to posterior manner, so I'm going to use a different picture. So let's use this image. Now, for what I'm talking about right now, do not pay attention to the gray line just yet. But what I'd like you to do is follow the same tract that we just did in the previous image. So I want you to look at the left side of the screen and follow that pink line. You're going to see that the initial nerve, the one that comes to the brain, when it descends, it's actually going to synapse with another nerve. This synapse at the brainstem is now on the left side of that person's brainstem. So it's already crossed over to the contralateral side at this synapse point. After that, this second nerve, this is cranial nerve 12. This nerve makes its way down to the tongue. And note, just one half of the tongue. We have two sides. From this pathway, beginning at the right side, we cross at the brainstem, and then cranial nerve 12 innervates the ipsilateral side of where cranial nerve 12 begins. We are at the left side of the tongue. This is a zoomed in picture of the same picture that we've been using to show you that the synapse is at the contralateral side of where that nerve first began in the brain. Now in this example, I do want you to consider that gray line. So let's say there's a lesion where it's circled on the screen. This lesion is occurring on the right side of the patient's brain at the level of the first nerve. This is going to end up causing an impairment on the left side of the patient's tongue. So a lesion that occurs in the CNS, aka the upper motor neuron lesion, this is going to cause a contralateral impairment. So the left side of the tongue is impaired. Now let's say there is a lower motor neuron lesion, so a lesion that occurs at the peripheral nervous system, and specifically at the second nerve of this pathway, which is cranial nerve 12. At the beginning of the second nerve, aka cranial nerve 12, the cell body of this nerve is already located contralateral to the side of where the first nerve started. So cranial nerve 12 is already on the left side of this patient's brainstem. A lesion anywhere along cranial nerve 12, so this left side is going to result in an impairment on the left side of the tongue. So a lower motor neuron lesion will result in an ipsilateral motor impairment. So as a recap, a right-sided upper motor neuron lesion is going to result in a left-sided tongue muscle deficit. A left-sided lower motor neuron lesion will also result in a left-sided tongue muscle deficit. Now it's time to clear something up. In this example, you see that the left side of the tongue is impaired. Well, why does it show that the tongue is then swaying to the left, swaying to the affected side? This has everything to do with the function of the tongue muscles. Cranial nerve 12 innervates plenty of tongue muscles, as we saw, and all of these have different functions. Now, I have mentioned that there is one muscle that we kind of normally care about a little bit more than the rest when it comes to cranial nerve 12 testing, and this is the genioglossus muscle. There's one on both sides of the tongue, so there's a left and a right genioglossus muscle. Now, when both of them are functioning as expected, when you ask your patient to protrude their tongue or stick out their tongue, the protrusion that we expect to see is straight out in front. However, when you only have one side working, the function of the muscle individually is actually protrusion and toward the midline. So if you look at the schematic, for example, look at letter C, only the right genioglossus muscle is working. So if you ask your patient to protrude their tongue, the genioglossus muscle is going to move the tongue forward and to the midline. So in this case, it's forward and toward the left because that is that midline. If you don't have the left genioglossus muscle to counteract this midline shift, that's why we see that left shift, that veering off to the left in this case. Now going back to this example, this is exactly what we see here. A lesion that results in a left-sided genioglossus muscle impairment, so it's either a right-sided upper motor neuron lesion or a left-sided lower motor neuron lesion. This is going to cause the patient to display a left deviation of the tongue when you ask them to protrude their tongue. So we're going toward the affected muscle side because there is no counterbalance against that midline movement coming from the right genioglossus muscle. Ultimately, we have already talked about the test. You ask your patient to protrude their tongue. If you see that it sticks out just right at you and it's in midline, we're okay. But if it deviates one side versus the other, then it's a matter of not only wondering if there's something going on with cranial nerve 12, but also, what part of the tract was affected? Lower, upper, which region is the lesion present in? Do you have imaging to maybe show your answer? And if you don't have imaging, can you use your critical thinking skills to find out by looking for things like atrophy or fasciculations, things that kind of veer to an upper motor neuron lesion versus a lower motor neuron lesion? If you want to pass the NPTE, it is all about learning the material in a different and more comprehensive way so that you'll understand material rather than just memorize it. Check us out at sptwithme.com when you're studying for the NPTE. Check out these references for more information.